more deaths from COVID, an estimated of up to 400,000 total deaths by February 1st. Our federal government has failed to respond to this travesty. Time and time again, when it comes to controlling this pandemic. Today, we'll be focusing on workplace exposures. The latest research shows that improving safety on the job is crucial to controlling this pandemic. Without the consent, workers are being treated like canaries in a coal mine, and that has to change. Black and brown communities, in particular, Black and brown workers who are overrepresented in essential occupations like meatpacking, agriculture, warehouse, all which have been devastated by this pandemic, suffering the highest rates of infection, illness, and death. Just today, there was a shocking report in the Washington Post that instead of protecting workers, managers at Tyson food plants in Waterloo, Iowa, had betting pool going to see how many workers would get COVID. Completely inhumane. These allegations of such callous behavior turn my stomach and show why we have to turn the page and take a new approach. We are hopeful today with new leadership in Washington, the Biden-Harris administration may take these issues more seriously. President-elect Biden's very first act, before he even named his chief of staff, was to appoint a distinguished panel of physicians and scientists to deal with COVID-19. This new team needs the facts and evidence we are sharing today to control COVID-19. We must make our workplaces safer. And we have a distinguished group of panelists today that I have the pleasure of introducing. We'll have Cheryl Mount, who is an RN for Virtual Health in New Jersey, who is also president of her union at the hospital. We have from the Harvard School of Public Health, we have Professor Nancy Krieger and Dr. Gregory Wagner. And when we get to the Q&A section, we will also have available two of Dr. Krieger's co-authors, Letitia Davis, a health consultant in Boston. And we'll also have Peg Seminario, who is a former health and safety director at the AFL-CIO and a national COSH advisor. So with that, let's get started. And I'd like to invite Cheryl Mount to talk a little bit about her reality. Cheryl?
All right, let me unmute myself. Hi, my name is Cheryl Mount. I am a registered nurse for 35 years. Most of that 35 years have been at the bedside caring for some of our sickest patients in critical care areas, ICU, cath lab, PACU recovery room, and rapid response team. Our local at Virtua has meticulously documented nearly 300 of our nurses being exposed to the virus that causes COVID-19. Many of us got sick. In fact, I dare to say that if you gave all 850 nurses in our local the COVID-19 antibody test, that most of us would come back positive. I believe I know the situation that caused my mild bout with coronavirus in April. I was caring for a patient recovering from anesthesia that required constant repositioning of her high flow O2 due to confusion and dementia. At that time, we were not wearing goggles and N95s for every patient. This patient decompensated, was sent to the ICU and was later tested for COVID-19, which came back positive. I was notified and quarantined. I had vague, mild symptoms towards the end of my quarantine period, but really didn't think too much of it. I was one of the lucky ones. 4 weeks later, I did take a COVID-19 antibody test at another facility where I worked, and it came back positive, showing that I did indeed have COVID-19. Across New Jersey, healthcare workers have filed complaints over unsafe working conditions, which have resulted in OSHA issuing some citations. Those citations, however, are from the direct result of HPAE's expert safety officer on staff at HPAE persistently pursuing the agency to investigate our complaints. In most parts of New Jersey, OSHA has been accepting the documentation submitted by HPAE's safety officer. Much to our disappointment, OSHA did not do a complete investigation of the complaints regarding Virtua, despite overwhelming documentation that we provided. We have since resubmitted our complaint because we have concerns that it was not handled properly the first time. It's taking the persistence of our frontline healthcare workers who are already overworked and exhausted to get OSHA to hold our employers accountable for our safety. We should not have to work so hard to get OSHA to do its job. The citations we have been able to get OSHA to issue are based on current standards that are not specific to massive pandemic situations. We need more comprehensive OSHA standards, and we are optimistic that President-elect Joe Biden will support these efforts. I cannot overemphasize how serious this is. The second wave of COVID-19 seems more serious because the increased incidental exposures like mine. This is causing serious staffing concerns. These staffing issues prompted our employer to recently change quarantine guidelines, requiring exposed asymptomatic nurses to work in direct patient care. We all know you could still be contagious without symptoms. This is a very serious and concerning safety situation. Would you want your family members taken care of by a nurse who has been exposed to COVID-19? Thank you.
Thank you so much, Cheryl, for your bravery and leadership. We really appreciate you joining us today. I'd like to pass it now to Professor Nancy Krieger. As I mentioned before, she's with the Harvard School of Public Health, and she'll be sharing some findings from the Federal Accountability Study. Professor Nancy? If you could unmute yourself.
Nancy, you're on mute.
Yes, my apologies. So I just want to say first, thank you for including me today. It's important that you have this press briefing. It's very important to hear your words directly, Cheryl, in terms of what your experiences have been and what your local is advocating for. What we did in our study demonstrates the importance of listening to workers' voices and workers' complaints. I assembled a team that was interdisciplinary, because you need that, of infectious disease epidemiologists, social epidemiologists like myself, biostatisticians, some extraordinary occupational health specialists, two of whom are on this call today, data analysts, data scientists, et cetera, so that we could actually try to understand something about what has gone wrong with the federal response to this COVID pandemic, which is killing so many. The reports today are of 250,000 dead. That's of those diagnosed with COVID, not the excess deaths, which are probably more on the order of about 333,000 at this point. So we did a study whereby we looked at both introduction of the virus into the country, we looked at workplace exposures, and we looked at the consequences with regard to racial, ethnic inequities. I will focus today on what went on with workplace exposures. We analyzed the OSHA data that were available on complaints for January 16th through September 30th. In that data set, when we analyzed it, there were 36,030 complaints. We also looked at all deaths across the country that were at that time attributed to COVID-19. That's 198,929 deaths. What we did is look at the relationship between when the complaints happened and when the deaths occurred. We also did this for the cases. What you can see in the top part of this panel is the black line is the deaths in this country, the death rate for COVID. The count of the COVID cases. And the bars that you see in the different colors are the number of complaints. And two things stand out. One, it almost looks like the complaints themselves look like an epidemic curve. They go up and down and up and down. And second, they precede the curve that we do see for the deaths from COVID-19. We then rigorously tested to see what was the relationship, the correlation between when the complaints happen and when the deaths happen. What you see in the bottom panel is what's called the heat map, where we look rigorously to see if across all the possibilities of what the time shift is of a lag, do the complaints happen before versus after the deaths that occur? And what you see is that the complaints where you see the yellow color, if we could go back to that slide,
Hang on just a second.
Oh, sure, is the strongest. What that shows is that we found between complaints and death 16 days later was when we found the strongest correlation with a value of 0.83, which is incredibly high. And if we looked even just among the healthcare workers, it was even higher at 0.95. So what this means, that's very important from a temporal order, is that the complaints precede the deaths. It's not as if workers are finding out that there are people in their community who are being exposed and are dying and then start complaining. No, what our data show instead is that workers started complaining and the deaths in their community followed. So that is a very important statistic. And what this means is that we need to be paying close attention to who is being exposed at work and what that then means for their family members, what that means for their community and for community spread.
Thank you so much, Professor Nancy, for that overview. Really appreciate it. I'd like to now present Dr. Gregory Wagner, also with the Harvard School of Public Health and a national COSH advisor, who's going to elaborate a bit more.
Thanks very much. I really appreciate the opportunity to be part of this panel. You know, obviously the whole public health community is distressed by the inadequate federal response to dealing with the pandemic. And workplaces are a critical place to address it. We hope that a new approach by a new administration can make a difference. So a colleague, Dr. David Michaels, who ran OSHA in the Obama administration, and I put together an urgent proposal that lays out 11 steps that can be taken right now to reduce risk to people who can't work from home and the people that they serve, the customers that they serve, and the communities that they live in. Right now, there's no coordinated federal effort to address the pandemic at all, much less address the risk to people who work. That needs to change. I want to highlight just a few of the points in the proposal. One is that federal leadership is critical. This can't be outsourced to individual businesses, to states. We need to have a coordinated, comprehensive federal program that cuts across all the different agencies that have something to do with worker health and safety and the economy if we want to have the country at work safely. We need, in order to do that, to have a OSHA provide the leadership that it's responsible for to assure safe and healthy working conditions. They can't do that alone. They do it through setting standards that tell employers and workers what's expected to create a safe environment. And we think that they should take advantage of their authority to put together an emergency temporary standard and issue it quickly to get things moving in workplaces, to set up programs that are workplace specific and begin to protect workers in their communities. In addition, OSHA needs to gear up its response to the kind of worker complaints that Nancy Krieger has identified, that there have been pitifully few responses. Less than 5% of complaints have gone on to have an inspection, and many have been closed out with just sending a letter or ignored altogether. This needs to change. The inspection and enforcement opportunities for the government need to be brought to bear on problems where they're identified, and workers who identify problems in their workplace and communicate them to their employer where things don't change and they're still at risk need to have their concerns responded to by the federal agency in charge of worker protection, and that would be OSHA. Their right to make complaints without fear of retaliation needs to be strongly protected, and workers need to be involved in the development of workplace-specific plans that can address in each workplace around the country the kinds of risks that people face. I just not going to go over all plans, recommendations. Most of them are immediately implementable and are based upon good and complete science to provide guidance into what needs to be done. It takes just the will to do it and the commitment to having this kind of coordinated protection of people.
Thank you so much, Dr. Wagner, for that overview and also for the recommendations that resonate across our network, and we are behind 100%. I want to thank our amazing group of panelists. Everything that we've heard today is consistent with the research and report from National COSH on this topic in particular, a safe and just return to work, prepared with the help from Dr. Wagner and many others in the scientists and practitioner community. Our view is that we need a worker-centered approach to confront COVID-19 in our communities. When employers make a plan, as Dr. Wagner has outlined, workers have to be involved in creating and implementing it at every level of government. If there are rules and regulations put in place to control COVID, workers must have a seat at the table. When inspections happen, whether in response to worker complaints or checking industry hotspots, experience and evidence from workers must drive the process as well. So we want to thank everyone for joining us. And now we're going to open it up to questions. And I'll have our communications leader, Roger, help us out.
Sure. Folks just want to unmute and chime in, or if you want to raise your hand in the chat. But the floor is open, so go ahead. You can ask whatever you want to the panelists, and if you just want to identify your name and news organizations.
I have a question. Dave Jameson with Huffington Post. Thanks everyone for doing the call. My question was for Cheryl. I was curious, what you thought of the fines that were issued in the cases that your union pursued. And I'm also curious, you made it sound like your union really had to stay on top of OSHA to get inspections to happen. I'm curious, if you think those cases only came about because you guys, really stayed on top of it.
Cheryl, if you could unmute yourself.
Thought I did, sorry. A double click. Thank you for the question. And like I said, much to our disappointment, we had over 10 very valid complaints, mostly surrounding faulty PPE, training and education on COVID patient care, very serious complaints. We had over 30 testimonies of employees willing to come forward and testify. And we got one very small citation for one single incident. So no, we did not get the citations we thought we deserved as healthcare workers who were put in unsafe working conditions. And that is why we refiled our complaint to get action and protect our members.
Thank you. Just a quick follow-up. Could you state again the name of the facility where you did get one citation?
I do work for the virtual health system.
And if I can just chime in here, I think it's also important to point out, as Cheryl did and Dave mentioned, these citations only came about because the union was dogged. I mean, the union took months and months to document, get worker input. I mean, this was not a small effort. It was a huge effort that was undertaken by HPAE, and that's the only reason this happened. The other thing that's important to point out, OSHA didn't issue the citations for like 5, almost 6 months after the conditions.
Correct.
And so what this meant was there was no obligation on the employer during that time to do anything. And what we're seeing with most employers is they're now contesting the citations that have been issued by OSHA. So.
Yeah, it's been very, very disappointing. And you'll hear a lot of nurses, and this is a phrase that almost makes me extremely emotional. We do feel disposable. They say we're heroes. We can't stand that term. But, you know, is a hero someone that's willing to go into the workplace without proper protection? No. We're just trying to do our job, and we want to do it safely and go home to our families and keep them safe too.
I see a question from Alexander. Thank you, Cheryl. I see a question from Alexander from the Wall Street Journal. Alexander, you want to unmute and just fire away?
Yes, so I'm happy to answer that. So first, I want to underscore something that Cheryl was just saying. In our analyses, and this relates to the question I've been asked, we also did text analysis of the, again, the 36,000 complaints. And what really stood out, again, this was for the, again, earlier part of the pandemic, separate from where we are now, the major complaints that came up in both Spanish and in English were about masks, were about gloves, and were about social distancing. So we did a text analysis to see how often words show up. Those are not part of the published paper, but that was certainly part of our preliminary analyses. And we could really see that with regard to specifically the healthcare workers as well. And I think in terms of the second part is that, yes, we looked at the lag for cases as well as for deaths. And the strongest lag for cases was about 10 days after the complaints. And the cases were, again, about 16 days later. So that makes sense because cases happen before deaths do. And it's important to remember that this is, again, the data that was through September, and particularly with regard to the first wave where there was a lot of information, there was a lot being learned then about patient care. So the lag between being a case, if you were a serious case, and dying was faster than it is now, where there's been more learned from the horrible experiences, but also the dedicated work of the healthcare professionals in how to actually reduce the fatality of cases once people are diagnosed. So it's important to remember that we're giving the on average around the correlations for the time period that we studied, which is only through September 30th. We're now in yet another phase of this pandemic in different ways across different parts of the country. This pandemic varies by region and it varies by time. So it's not that we expect that these correlations per se are exactly fixed, but it is still striking when we looked across data across the whole time period for both cases and for deaths. The lag was clearly in the temporal order of complaints come first, then the cases, then the deaths.
Thank you so much, Professor Krieger. Any other questions?
Yes, hi, this is Rachel Axon with USA Today. A question for Dr. Wagner. You were saying that an emergency temporary order is something that could be enacted quickly. My team has been reporting on COVID outbreaks in meat packing plants. How is that something that a new administration could do quickly? And then what challenge do they face in the enforcement end when OSHA is as understaffed as it is on that front?
Dr. Weiner, if you can unmute yourself.
Thanks for the question. Right now, California, for example, today has considered an emergency temporary standard that could be a blueprint for a kind of standard that the federal government could get out quite quickly. It needs to go through the proper administrative process, and it is an expedited process that can get an emergency standard in place relatively quickly that can last for 6 months. You are correct that there are challenges with having the availability of enforcement personnel, inspectors, but with the presence of a clear standard, employers will know what to do. They actually, as a whole, don't want their workers to get sick and die. It's incredibly disruptive. It's bad for the economy. So giving clear, enforceable standards that say, get together a plan, implement it, engage everybody who can benefit from it, and get moving, providing a combination of the carrot and the stick, the technical assistance to help people put it in place, as well as the opportunity to enforce if there are employers who really don't want to get something in place. Then this is something that the federal government can do, and it's critical that they do it.
Just wanted to follow up. When you say quickly, what do you mean by that? And the time frame of a federal bureaucracy, what's realistic that can be done there?
Yeah, it looks like Peg wants to say something. I feel that it would be possible, especially with the advanced work prior to the January 20th, to have something in place ready to publish, but then it has to go through a certain number of steps, and
No, it doesn't.
the temporary standard could get
Right.
out immediately. It is an expedited process.
Yep.
And now, will there be something in place on day one, ready to publish? I don't know, but it would be terrific if it could be shaped and ready to push the button.
Just to follow up on that, I agree. California, as Greg said, is about to adopt a emergency standard today by their state plan. Virginia adopted one back in July. Oregon has adopted, Oregon OSHA has adopted, Michigan OSHA. So, states are moving. And these are legally, in place protections for workers. And Fed OSHA had done a lot of work on an infectious disease standard, which the Trump administration buried. And so we think that, they could move, immediately. Certainly, it's going to take, a little bit of time to get, people there and, sworn in and to do their jobs. But within a couple of weeks, they could have, on day one, they should be ready to go with the standard. A lot of work has been done. There are a lot of, good work that's been done on this, and now the feds need to move. The unions, petitioned OSHA to do this back in March. They refused. Trump administration refused. The unions litigated it. Unfortunately, they lost. And so this has been an ongoing effort, and and President-elect Biden has committed to issuing a standard to protect workers from COVID.
And it's important not to think about this only as worker protection. It's community protection. It's keeping people from getting sick, and with workplaces as being a key central focus for where risk is higher for many people.
Yeah, that's
what I would like to add on that about the community spread is also thinking who these workers are in relation to, among other things, race, ethnicity, and economic level. So what we document in the part of our paper that's about the racial, ethnic inequities is we show that the relative risks around the mortality rates among working age adults, they're on the order of 5, 10, and higher among workers of color compared to the white non-Hispanic population. And the relative risks are lower at older ages because on one hand, ultimately, it's true that everyone does die. But the point is with COVID is that it's at these working ages that you see these dramatic, horrific, preventable excess risks of death, particularly among African-American or Black and Latinx, and then also in a different way among American Indian populations in this country. So the point is that where does that come from? The COVID doesn't just drop from the sky. It goes through how people move and where people congregate. You'll note that right now there are studies that are being done about mobility, for example, and showing how much people congregate in certain areas for certain times. Generally, those studies, at least as they show up in the popular press, are framed predominantly from the standpoint of people who are quote unquote consumers. But who are the workers at those grocery stores where people are consuming? Who are the workers at the retail places where people are shopping? Who are the workers that are actually making the industries make it possible to even ship all the packages out? Who are the workers that are working at all different levels in the hospitals? There are the ones who are providing direct care for patients, but there are the janitors, there are the orderlies, all of those people. Who are the people that are moving people around on the buses and the subways to make sure that people can get back and forth? That's what you're also seeing reflected in here. That comes home. That's where communities transmission starts.
Thanks so much, Dr. Krieger. Joe Maniscalco, you got a question? You want to speak up? Unmute yourself?
Yeah, hi, can you hear me?
Yes.
Yeah, so what kind of changes you think ought to be made, can be made to make OSHA more durable during another Trump administration that spawns down the line?
Let me take the first crack, and then I suspect that Peg will help supplement any answer. And first of all, if you want to try and make sure that it can be responsive to the next pandemic, then Peg mentioned the infectious disease standards that was pretty well, it was a comprehensive standard that was pretty well ready to move at the end of the administration prior to the last one, to the current one. The 6-month period with an emergency temporary standard would put OSHA in a much better position to move that forward, get a comprehensive infectious disease standard that would be applicable in any future pandemic response. Staffing up in order to be able to improve inspections and enforcement. Improving the protection for whistleblowers now is really phenomenally weak, and trying to move forward with improved protections of whistleblowers would be possible in the course of the next administration. There's a list of things, you know, in part, some of it comes up in the list that we have, but even getting coordinated with things, somebody mentioned the meat packing. The Department of Agriculture has responsibilities for line speed. Line speed has a tremendous impact on the risk to workers who are working in the meat packing or the poultry industry. They need to coordinate with the safety of the workers in mind and in developing their standards for line speed for worker protection. And you can go across many industries where OSHA's protections, they're statutorily limited, but you have other parts of the federal government, whether it's the Department of Transportation, looking at long distance truckers and airplane safety, and on, that there are a wide range of government agencies that need to get coordinated, and the work around coordination of worker protection from COVID could be a first step towards much improved government-wide coordination for worker protection in general.
This is Jessica. If I could also add, I mean, the emergency temporary standard is definitely a step in the right direction. And I think it's also a real good tool for workers. But the important thing to note too, that OSHA as an administration, both for state plans and federal, are great. It's a greatly under-resourced agency in terms of, in practicality, how do you enforce these standards? And the reality is that for us at National COSH, being able to empower workers, providing them the tools to be able to use these standards as a weapon to protect themselves is really key. We have seen that in California, for instance, and in many other states. We're exploring this idea of worker councils, which is workers coming together along with public health representatives, folks in other worker advocacy organizations, looking to somewhat deputize workers with the ability to report these hazards more freely, to systemize it in a way that will allow for OSHA and any other agency to come forward, demanding the employer do the right thing in protecting these workers. So again, I think it's important to emphasize that it is an agency that's under-resourced. We know things will not happen magically in a couple of weeks and months, but being able to have a standard at the very minimum to allow workers to move forward, take action, whether it's directly worker employer, is key to being able to minimize the impact of COVID in this case.
Thanks, Jessica. I think Juliana from the Philadelphia Inquirer has a question for us.
Hi, yes. I was wondering if there are any best practices around how employers should handle workers who go out on quarantine because they're exposed on the job. We're seeing some employers here in Philly say that they're no longer going to pay workers to quarantine when they're exposed on the job. And I'm wondering, what the consequences of that might be.
This is Peg Seminario. When you think about the quarantine, the reason why they're quarantining the workers who have been exposed is because that person may become positive. And so they're going to expose other people. So it's really controlling the source of exposure. And in the workplace, that's the employer's responsibility. something that, so in this case, unfortunately coming from a worker. And so that's why, the CDC from day one has said that, not only cases, positive individuals, but people have had a close contact, and they define that now as a cumulative, 15 minutes of time in a working day, that they should be quarantined. And they've said, previously for 14 days. They have a little asterisk on that, unfortunately. This is, oh, but if you're an essential worker, well, then it's okay if you go to work as long as you wear a mask and you check your symptoms, even though we now know that asymptomatic individuals spread it. So it's really to have that individual quarantined, and the person, if they are not going to get paid, they're not going to come forward and say that they have been exposed. They're not going to come forward and say that they're sick. And so it really should be on the employer to pay that individual the time to be off work. And quite frankly, it would be a whole lot easier if we had, paid time off legislation, as, the paper that Nancy and others put together, points out. In fact, we don't have these social safety nets in these systems get really exposed, during this crisis that we are facing. But it's critical to quarantine and pay those individuals to make sure that everyone else is protected.
Peg, thanks so much. We're at 40 after the hour, so we should probably wrap up soon, but we would have time for 1 or 2 more questions if anyone's got anything else they want from the panel.
This is Rachel from USA Today again. Sorry, I'll jump back in. I think Dr. Wagner would be best for this, but anyone else feel free to jump back in. The infectious disease standard that OSHA had been working on, I think 2009 on, and that got shelved by the Trump administration. How is that something that may be enacted in the future? Maybe not a quick solution, but longer term, something that could help address COVID and other situations that we might have in the future.
Enforceable standard is something that is clear. It gives clear responsibilities. In general, employers always have a responsibility to maintain a workplace that's free of recognized hazards. So they have that general responsibility now, but there can be a lot of concern, uncertainty as to how you address specific standards. What a comprehensive infectious disease standard would provide is a kind of point by point, this is how to get ready for it. This is how to anticipate it. This is how to plan. And this is how to act if it happens. So it really will give a blueprint in advance so that you don't have this fumbling around and the long time lag. If you've looked at what happens in an infectious disease epidemic, you start small, but if you let it fester, it gets bigger and bigger and bigger. And that's where we are now. You want to nip it at the bud, and an in-place infectious disease standard can nip it in the bud.
Thanks. Anyone else have something to add on that topic?
What I would add is that what's very particular here with COVID is that it is airborne. So for example, there are other infectious diseases where you're not going to have airborne transmission at work. And it's not just that it grows exponentially. So it's really important when you have something that is airborne that could be transmitted in that way. You also have other kinds that will be transmitted more through droplets on surfaces. You will have other kinds of infectious diseases that could be transmitted, particularly with healthcare workers who are exposed to bodily fluids. But that's a very different set of kinds of exposures and spread. Here, this is something which is airborne. And it really, really matters. So it matters for the people who are at restaurants and are workers there, because there are people coming in who it's not just only about the people that are dining on their risk, it's the risk of the people that are working at the bars or working at the restaurants. So that's a very different, and that needs to be addressed very clearly, because there are an awful lot of airborne infectious diseases. And if you don't have vaccines for them and you don't have other curative measures available, it's essential regardless to prevent transmission. That's primary. That's the role of public health.
Thanks so much, Professor Krieger. Time for one last question, if anyone has anything else we haven't covered. Well, it's been a great presentation. I know we hit a lot of points. Anything else people want to follow up on? I've dropped my email in the chat, and everyone on the call will get a press release from us. It'll have our contact information. So if something comes up or you want to talk to one of the panelists some more, and you should all have copies of the studies that Professor Krieger and colleagues did, and Dr. Wagner and Dr. Michaels prepared on the urgent proposal. We circulated all of that, but anything we didn't get, please feel free to share around. And I just see another good study dropped in the chat, so I will share that one around as well. Anything else before we go? Thanks so much to the panelists. Thanks for all the journalists who joined us, and feel free to follow up if you need more information.